Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning, GI Tract.
We're going to spend this session focusing on the alimentary canal. The alimentary canal is the GI tract from mouth to anus. I'll be demonstrating several positions in a little while, but let me explain that protocols or what projections or positions that you take will vary very vastly between radiologists, between the physical imaging department setups, between patients. So my approach when I demonstrate the positioning will be to show you a wide range of different scenarios that you may be dealing with. We need to talk about a few of those situations now. The examination might be inclusive of the entire GI tract or only portions of it. For instance, you might be just focused on the esophagus. You might be just focused on the upper GI or the stomach, which may or may not include some of the esophagus. It might be a small bowel follow-through series, or it might be a colon exam or large intestine. Many times we refer to a comprehensive study as a complete GI, which is predominantly an upper GI or the stomach focus and the colon focus. If you are faced with a protocol for a complete GI, it's important that you do the colon examination first. So the enema is presented into the large bowel and the patient is able to empty out their colon and most of the barium will leave, and then you do the upper GI series. That's one thing to keep in mind if you're doing multiple exams in this scenario. An esophagus, you might do that first, have the patient drink the barium for the esophagus, and then you go into stomach filming after that. Again, a lot of different options are going to be available to you. Every institution will have a protocol procedure manual that you can look up different doctor routines. And this demonstration will be covering probably 90% of possibilities that you will see. So not only are you going to be dealing with different scenarios, it's patient habitus that is going to be probably your biggest challenge. And our 4 categories of patient habitus deals with sthenic, that's the average patient build. You have hyposthenic, which is a smaller than average build. You have an asthenic build, which is very tiny or very petite, especially if the patient's elderly. And then you have the hypersthenic, which is an obese type of patient. So again, 4 different types of body habitus, sthenic being average, hyper being excessive to normal, hypo just under average, and asthenic is very, very tiny. So when I do the demonstration today, I will be emphasizing those different body habituses. Generally speaking, an upper GI consists of, well, not the upper GI, but the gastrointestinal system. The doctors will do some kind of floral procedure to begin with. They will watch the patient ingest the barium. They will insert the barium through an enema procedure. They might be taking gastrographin if the patient is suspected of having a visceral perforation, or the patient might be heading for surgery for some reason. But generally speaking, the doctor does the preliminary review of the patient under fluoroscopic procedures. The physician leaves, and then we as technologists will come in and take what we call overhead projections or films after the fluoral, and that's what the purpose of the demonstration is today. Not fluoral setup or not what you do during fluoroscopy, but it's going to focus on the overhead projections afterwards. And I will start with a logical order from the esophagus, stomach, we'll talk about small bowel, and then we'll talk about colon. Let's go to the table. We'll see you in a minute. I've got our patient Kristen set up for an RAO of the esophagus. Again, I'm going to start from the mouth and work my way down through the system. And remember, you may be taking this in different orders. The doctor's protocol will actually dictate what precise positions or projections you will be doing. But let's take a look at our patient here. For an esophagus, we generally use a 14 by 17 film. I have the ID to the top, and the right marker is moved in a ways because I will be showing collimation on the two sides. The film's edge will be level with your patient's mouth. The top of the film will be level with your patient's mouth. The esophagus, the patient swallows barium, and the stomach is approximately here. So you can see the esophagus will be the focus of this film here. Now I'm going to have you focus on our patient's back and look at this crosshair here. I'm going to try to demonstrate. Her spine is right here, the spinous process. And this crosshair is anterior to her spinous process, approximately 2 inches. It'll depend on the degree of obliquity that you position your patient in, but you've got to remember that the esophagus is always going to be anterior to the spine, no matter what position the patient is in. So here's the spinous process. We know the vertebral body, and then the esophagus. Another trick that you can use, here's Kristen's neck, and I've got this crosshair coming right down almost the center of her neck, a little bit on the anterior side. So I know that between being a couple inches off the spine and coming right down her neck, that I have not missed her esophagus side to side. Again, the film's edge will be level with the mouth. The trick here is to gain your patient's cooperation. Explain to them that it's going to be necessary for us to swallow the barium that's in the cup, for them to keep drinking, and to try to take big mouthfuls and take big swallows in order to catch the barium in the esophageal tract. And we're choosing to do the patient in a recumbent position because gravity will assist us in it. You would position the patient exactly the same way at the vertical board, but as they swallow, the gravity will assist that barium going down faster, whereas when they're recumbent, at least swallowing the barium goes not with the flow of barium. So it's our recommendation that you do patients for esophageal studies in a recumbent mode. Again, your option would be to do it in a vertical mode. Again, we talked about cooperation with the patient, and they have a cup of barium. There's a straw, and again, you've explained to the patient what your job is, and I'm going to have you taking a big mouthful and watch them. She actually has a straw, and then you'd go to your exposure panel and okay, taking another big mouthful, swallow it, and you're trying to watch the epiglottis, and recommend on about the 4th swallow, you watch the epiglottis, and when it goes up, when it moved up, the esophagus opened up and the barium went down. So you try to press the expose button at the time that you see the epiglottis go into a vertical motion. And hopefully we catch the barium in the esophagus. Again, the positioning, RAO is a very common oblique for esophagus, usually 30 to 45 degree obliquity. Another common position that might be used for an esophagus is a lateral position. And you might do a left lateral or you might do a right lateral. For the sake of demonstrating here in the camera angle, we're going to turn our patient into a right lateral mode. Oh, there you go. And patient can face the camera. Get them comfortable in a true lateral position. Arms forward. And then they're going to hold the cup again. Make sure they're straight on the table and in a lateral position, checking their hips and their shoulders. And the film's edge will remain at the level of the mouth. You would change cassettes, and with a right lateral, I'd use a right marker, again moved in a ways. And the film's edge will be level with the patient's mouth, and then think back what I said a few minutes ago. Where is the esophagus? Where is the esophagus in relationship to the spine? It's just anterior to the spine. So we're going to slide the tabletop towards me. And I'm going to look at the patient's body, and there's their spine. That would be the mid-axillary line. You know that from your thoracic vertebrae and your lumbar spine vertebrae exposures. And then the esophagus is just anterior to the spine. And I can also look at the patient's neck, that trick that I talked to you before, and make that crosshair come right down there. Okay? And the instructions to the patient would be the same. Let them know that it's important for them to take big swallows when you say that it is difficult to catch barium in the esophageal tract, and have them take about 4 swallows and make your exposure if you can see the epiglottis go up, or you just hope luck is with you if you can't see the epiglottis go up. You might do other obliques, but again, if you remember the film's edge level with the mouth and where the esophagus is anterior to the spine, you'd be able to do any position that a physician would ask you to do for an esophagus. Okay. Some techs like to take the barium and make it thicker, or there's gastrographin. Sometimes there's barium tablets that patients take. Sometimes it's a little cotton ball dipped in some barium if they're trying to detect a foreign object. So you're going to run into all kinds of scenarios out there doing your GI work. We're going to move on now to a stomach exam, and since our patient's in a right lateral position, we might as well position for a right lateral. Again, these, I'm going to demonstrate them not in any set order. If your patient is left in a supine position, in an AP position, you would start with your APs first. If they were left in a prone position, start with your PAs first. What you want to keep in mind is that you don't make the patient move one way, move them back another way. Think logical and have your patient move, say, in a circle, one direction or the other. So the patient has to move as little as possible. Now, the big films are for the esophagus. We'll move to 10x12s for most of the stomach or the upper GI films. And we will not use an L or an R marker. We will just use tech initials. I'm placing the cassette lengthwise in the Bucky tray for a right lateral. And the ID is to the top. Collimate to your 10x12 lengthwise. Okay. And she's in a true lateral position, shoulders vertical, the pelvis vertical, truly lateral. And then I'm going to find the tip of the scapula and the iliac crest, and I'm going to go halfway. Can you see my fingers here? I found the tip of the scapula and the iliac crest, and I'm going to go halfway. That's my halfway reference mark. That is approximately the level of L1 or L2. Okay? Here's the crest. L3 is 2 inches above. And you can see that my halfway mark is approximately at the level of L1 or L2. Ballingers will give you that option that you should be centered at L1 or L2. We're giving you a more precise centering, giving you something to go for. And again, it was the tip of the scapula, iliac crest, halfway, and then a little bit below. I think I failed to tell you a minute ago that you should go an inch below. So let me recap. Tip of the scapula, iliac crest, halfway, and 1 inch below. That will put you at the level of lumbar spine, L1 or L2. You can confirm by iliac crest. 2 inches above is L3, so you can see that I am approximately at L1 or L2. That's for the vertical placement. And I consider Kristen to be a sthenic body habitus, an average level body habitus. Now, the front and back plane, I'll try to tighten her sweatshirt here a little bit. And her mid-coronal plane, I'll try to demonstrate it with my hand right here. There's her mid-coronal plane. I'm going to want the crosshair approximately 1.5 inches anterior to the mid-coronal plane. So I'm going to come around and float the tabletop backwards a little bit. Mid-coronal plane, and you want to be 1.5 inches anterior. Now I'm going to have you focus on the tabletop here. When I did that, look what happened. I'm actually X-raying tabletop. I have my 10 by 12 collimated field set with the gauge, and if I'm showing tabletop, I'm giving the doctor no valuable information there. So I'm going to adjust that centering a little bit to give him more of the body, give her more of the body, to see perhaps more of the stomach or small intestines. So one of the things that we just experienced now is your instructors or you as a tech are going to give you certain reference points. I'll recap that one in a minute. But if you ever X-ray tabletop, the rule is that's not valuable information. Alter your positioning. Do not demonstrate tabletop. Give the physicians the body to look at. Give them some GI to look at. Right lateral, tip of the scapula, iliac crest. Divide that halfway and go down 1 inch for sthenic body habitus. Mid-coronal plane, you should be anterior to the mid-coronal plane, approximately 1.5 inches, but since we were showing tabletop here, I actually moved the patient this way to include more of the body. And this would be a right lateral. Change cassettes, and I'm going to go crosswise, and we're going to have the patient roll onto their stomach. And they're going to go into a PA position. Both arms up, both arms down. And I'm going to a crosswise mode because the stomach, when you're in an oblique or a lateral position, the stomach tends to elongate. So the film goes lengthwise. When the patient is in an AP or a PA position, the stomach tends to go more transverse. So we want the 12-inch axis to be wider across the body. And I'm putting the ID blocker towards you, towards the tech. And here's her left side. The fundus of the stomach would be here, and then the body and the pylorus comes to the patient's right side. So if we track that on a film, I want you to look here for a second on the cassette. Fundus is on the left side, and it circles around into the body, and the pylorus ends up over here. So I'm looking at the ID blocker and I'm going, but it might be into the fundus. That's a true statement. It might be into the fundus. So if we reverse the cassette, here's the fundus, circles around to the body, comes over to the pylorus, and now the ID blocker might be into the pyloric region. So you're kind of in trouble perhaps either way. Well, if you were to recognize the fact that say 80% of pathological conditions happen in the pyloric region, that's the area you want to protect. You want to put the ID blocker towards the fundus then. You want to keep the pyloric region free of possible obstacles. That's our rationale for putting the ID blocker towards you as the technologist. You've got to change the direction of your collimated field. We do not have automatic collimation here, so now I have to make sure I go 10 by 12 crosswise. Tube and the film are lined up, so now all I have to do is focus on the patient. We know the stomach is on the left side, slightly off of midline, so I just moved the patient to that area. Now I'm going to use my reference marks again. I'm going to find the tip of the scapula, top of the iliac crest, feeling posteriorly, and go halfway. Okay. Again, tip of the scapula, iliac crest, go halfway. That should be at the proximate level of L1, L2. Here's the crest, 2 inches above is L3, so you can see that I've confirmed that I am at the level of L1 or L2. And then side to side, here's her spine right here, and I'm 1 inch to the left of the spine. Because again, the stomach is fairly midline. It is on the left side, but just off of midline. So I'm happy with that placement. Then I like to look at the edge of the body here and make sure I'm not X-raying tabletop. Now Ballinger's actually recommends that you take the spine and the lateral aspect and center over the left side, but you can tell if I scooted the patient any further that way, I'd be x-raying tabletop. So I'm going back to that rule of thumb. X-ray tabletop gives the doctors no valuable information at all. Do not x-ray tabletop. So our centering is a little bit different than Ballinger's, and we've just given you rationale behind that. And I've demonstrated a couple stomach positions for you. So we need a little bit of a break, so I'm going to talk in theory some more. I mentioned that Kristen was a sthenic body habitus, or average. The positioning reference marks that I'm giving you today are baseline for the sthenic body habitus. And please recall for just a minute what the 4 body habitus were. You've got average, you have above average, you have slightly below average, and then you have tiny. Okay, let's focus on Kristen's back because it's really easy to demonstrate on a PA what we would do for the various body habituses. Again, this is a sthenic setup. You've got your tip of your scapula, your iliac crest, and you're halfway. Well, if Kristen was overweight, she would be considered hypersthenic. And what you do, instead of being halfway, you move up 1 inch. You move superiorly, because the stomach, the adipose, tends to make the stomach higher in the patient. So instead of being halfway, you're up 1 inch. This would be if Kristen was hyposthenic. Okay. Halfway mark is for sthenic. Now if she's underweight, you would take the iliac crest, tip of the scapula, go halfway as your baseline, and then you would drop down 1 inch for the hypo. And if she was asthenic, that's even tinier, the stomach drops even more, you're going to be 2 inches below. Okay? Again, you know, don't x-ray tabletop, the side-to-side method. Okay. So, hyper patient, hypersthenic patient, the stomach is higher, center a little higher than normal. Sthenic, we're making you memorize those part film reference points for the sthenic patient. Hyposthenic, just under average, so you drop down 1 inch, and asthenic, you actually drop down 2 inches. Okay? Hypersthenic, hypo, and asthenic in 1 inch increments for the different body habitus. Okay, let's go on with another demonstration. Okay, we did a right lateral. We've now done the patient PA. We're going to, it would be hard for you to see a left lateral, but it would be the same as for a right lateral. Okay, let's try to do it anyway. The camera, I can talk you through it. So, Kristen, would you face that wall for a left lateral? Left laterals aren't real common, but you might see it. And if you remember, when a patient is in a lateral or an oblique position, the stomach tends to elongate. So we're going to go 10 by 12 lengthwise. Adjust the collimation back to a 10 by 12 field size. We're going to straighten our patient up so they're straight on the table and they're in a lateral position. If the patient was squirming on you or uncomfortable, go ahead and put a sponge between their knees. That will make them more comfortable. And I'll work from this side of the table. I think we can see here. I'm going to use the tip of the scapula, iliac crest. We'd go halfway and then down 1 inch. This would be for sthenic. And then mid-coronal plane. I want to be a little anterior to it, but from my view now, I'm actually x-raying tabletop, so I'm not going to move her forward to truly set the 1.5 inches anterior to the mid-coronal plane to the center of the film. Now, obese patients, you're going to have a lot of tissue out here, and you need to keep in mind that a patient might be large, but they could be firm. Organs are going to tend to be held in place. If a patient is large and not firm, the stomach will tend to fall more forward. So what we're giving you are not precise positioning reference marks, they're guidelines. And you must think of patient habitus and think of patient condition and adjust accordingly. That's one of the pleasures of our jobs, because we're not button pushers. We do have to think through this. Okay? So this would be a left lateral, tip of scapula, iliac crest, halfway and then down an inch. This would be for sthenic. What if she was hypersthenic? What if she was larger? This is sthenic. This would be hypersthenic. This would be hyposthenic. And this would be asthenic. Again, approximately the level of L1 or L2. And if she was really tiny, we're actually at the level of L3. And little tiny are your 80, 90-year-old pound little old men and little old ladies. That there's no muscle tone and everything shifts down. I've actually taken an x-ray of a stomach that was entirely in the pelvis because of muscle tone. Everything just drops. Okay. Kristen, I'll have you turn on to your back. There you go. Notice we're having her go in one direction. I don't want her tipping back and forth. What way should I put the cassette, gang? Crosswise. APs and PAs, the film goes crosswise. Again, the ID blocker will be towards us. Her fundus is here and her pylorus is here. Fundus, pylorus. In the AP, the ID blocker is not a problem at all, but to help minimize your memorization, for crosswise films, we put the ID blocker towards the tech, and when the film is lengthwise, we put it superiorly. Again, trying to make your life a little simpler in memorizing things. Change your film collimation to match your film. Okay. And now the reference part for a sthenic patient. Again, the stomach is fairly midline, slightly to the left side. I'm going to use her xiphoid process, and I'm going to be 1 inch inferior to that, 1 inch below, and I'm going to be 1 inch to the left because the stomach is slightly off to the left side. I'm going to look over my patient and make sure I'm not x-raying tabletop. And I'm not x-raying tabletop, so I'm happy with that position. If she was hypersthenic, we'd be level with the xiphoid. This is sthenic, is 1 inch below the xiphoid. Hypersthenic is 1 inch above the standard line, which is actually right at the xiphoid. And then hypo is 1 inch below, and asthenic is 2 inches below the sthenic mark. Okay. On somebody who's very thin, they're not going to be very wide. You're probably going to be centered right at the midline because you're going to be showing x-ray tabletop over there. Again, you adjust for different body habituses. Okay. Kristen, the only one I think we have left is an LPO. We did an AP and a PA. We did an RAO. We did the right and left lateral, so an LPO. Okay? We're going to bring this arm over your chest. Just bend the knee slightly, and we're going to roll you like a log. 30, 45 degree obliquity again. If they have troubles holding in place, don't hesitate to use a positioning sponge. Is that more comfortable? Yeah. Cassette will go lengthwise. ID to the top. Fix your field size. And the xiphoid again. Find the xiphoid. And I'm going to be 2 inches below the xiphoid and approximately 2 inches to the right of the xiphoid. I'm going to look at the patient and I'm going to see that it's centered. Her body is centered to the frame. I don't know if the camera can look at this angle. The reference again is 2 inches below and 2 inches to the right of the xiphoid. But when I looked at Kristen, I'm going to alter that a little bit because of the degree of obliquity, and I'm only going to be approximately 1 inch to the right of the xiphoid. I'm looking at the collimated field, this box, and I'm centering it to her body. And if the collimated field is centered to the body, there's no way you're going to miss the stomach. Okay? Now, if a patient is really obese and the tissue falls this way, you're going to have to tend to shift and be centered more over here. Okay, again, you have to use some logic in finding the stomach side to side. Okay, I've centered her body and I am 2 inches below the xiphoid. Again, that's approximately the level of L1 or L2. Here's the crest. 2 inches above would be L3. So you can see I'm approximately L2. So I'm happy with that centering. Okay, we're going to let Kristen relax for a minute. If the patient was hyper, you'd raise the central ray. You know, you'd have to center higher. Hypo, you center 1 inch below the reference, and ascenic 2 inches below the reference. If there's a small bowel follow-through, the small bowel follow-through, consider them as KUBs. If there's a small bowel follow-through, generally speaking, you should make note of the time barium was first ingested by the patient. Then they normally do a few overhead films for the stomach series. Then they will do the follow-throughs, and the follow-throughs are basically straight KUBs. They may be APs or PAs. Think logically now. Where is the small bowel? Is it anterior or is it posterior? Tends to be in the front of the patient. So PAs are actually, the small bowel would be closer to the film, so when you can do PAs, it's actually better. But many times the elderly cannot go onto their stomach, so you would do APs. What the doctor protocol calls for, that's what you'll perform. Or logically, if given the choice, you prefer to do PAs with APs as a secondary backup. You'll get good films, but they just won't be as good as PAs. And the small bowel follow-through, the exam may last an hour, hour and a half. It may go 3 or 4 hours. Until the barium reaches the ileocecal valve, you are taking intermittent radiographs. In the beginning of the series, they're usually 15 minutes apart. Later in the series, they're probably a half an hour apart. The doctors will evaluate every radiograph after you take it, and then they will give you an indication of when to take the next one. So we're going to pretend that this one's our 15-minute follow-through. And we're going to have our patient be onto her stomach. If you're not doing a small bowel follow-through, but the protocol calls for a 14/17 of the stomach, try to do that one near the end of the procedure, because the purpose of the big film is for small bowel. The purpose of a big 14/17 film is not for the upper GI, it's for the small bowel. And the small bowel is distal to the stomach. Okay, so big film, we're going to put her MSP to the center of the film. I'm going to get her straight on the table. (14/17) cassette. The big films, you use markers. Little films, just initials. And I would actually mark how many minutes this was. I would have a 15-minute marker, say, here as well. In the lab here, we don't have those markers, but in the hospitals you will. So a 15-minute marker here might be half an hour, could be 45 minutes, could be an hour. Whatever the time frame was, that's what you'll put on your cassette. And collimation is 17/14. And if the patient allows, you can come in tighter. I'm going to put the mid-sagittal plane to the center of the film. Arms either both up or both down. I can collimate just a little on this patient. And I'm going to position as if it's a KUB, just to show you here. Here's her iliac crest. And I'm putting the center of the film to the iliac crest. Now what I like to do is find the stomach after I do a KUB. I'm validating my decision that it's okay to do a KUB. Here's the tip of her scapula, iliac crest. Halfway is the stomach. The stomach is right there. And I look at the film's edge, and you can see that the film's edge is going to clear that stomach. So I am happy with this patient being on a 14/17 film with the iliac crest to the center, because I verify that I'm actually putting the stomach here. and small bowel goes down here. Now if I had a 7'2" person, I'm not going to be able to do a straight KUB. I'm going to have to center above the crest because the stomach will be higher. Your intent is to put the stomach at the top of the film, small bowel in the center of the film. Now, during a small bowel follow-through, maybe an hour and a half into the procedure, the doctor sees something on your overhead films and they may say, let's go do floral. You need to be ready for that. They may want to do an overhead spot in that case. And then you'd come back to taking your overhead film. So be ready for anything with the small bowel. And one of the best hints that I can give you is to make sure the patient knows that this exam may take a while, that the actual length of the exam has nothing to do with you or how busy your department may appear to be. It is solely dependent upon how long it takes the barium to reach the ileocecal valve, and every patient is different. Could be an hour, it could be 12 hours. So make sure they understand it, and then keep the patient posted as to their progress of the barium following down into the small bowel, reaching the ileocecal valve. We're going to take just a pause for a second and be back.